advances in pharmacotherapy on obesity. But I will talk about other people than diabetics. Dr. Adler concentrated just on diabetic patients. And as we know that obesity is a real disease, so it needs treatment, and the treatment, like other chronic diseases, will take a long time. We know that obesity is a complex of many factors, like genetic, metabolic, physiological, environmental, behavioral, and even psychological factors all can integrate and behave to cause obesity. Also, a change in the body's metabolic set point is very important, because everyone has a metabolic set point that adjusts his weight. So reaching that set point, the body is refused to eat, and the metabolic rate is accelerated. When this set point is not activated, the one or the patient or the person, the individual, feels to eat, increased appetite, and he eats more, and so his weight will increase. And as we know, we have so many stages or grades of obesity. We have the normal person according to the body mass index, and the overweight one from 25 to 30. From 30 to 35, we have class 1 obesity. From 35 to 40, we have class 2 obesity, and we have the morbid obese person above 40. And we know that controlling obesity is very difficult, because it is a multifactorial problem. We have so many hormones and cytokines and other factors are regulating the food intake. So it is very difficult to control all those factors to keep the normal weight. We have FDA-approved medications for weight loss beside lifestyle modification, and when those agents fail, we go to the bariatric surgery. Dr. Farid will tell us about after this presentation. We have those medication, sibutramine, which was called Meridian in the past, and all of you that know that it was withdrawn from all the market more than 10 years ago, because it's cardiovascular complications and central nervous system complications. We have phenetramine also, and we have diethyl propionate, and we have orlistat. I think orlistat is still used till now for controlling or reducing the fat absorption and controlling obesity. We know that from this study that was done in January 2010, it proved that patients, whether diabetic, cardiac, or both cardiac and diabetics, receiving sibutramine was affected significantly as regard the cardiovascular system, and that leads to withdrawal of the drug from the market. We have many potential molecules to be used for obesity. Some of them have been already approved by the FDA or other authorities, like GLP-1 receptor agonists, like oxyntomodulin, like human growth hormone fragments, like amylin receptors, ghrelin, DDP4 inhibitors, or increased incretin-based therapy in general, like GIP, whether alone or in combination with GLP-1, like in tirzepatide. So those are potential molecules to be used in the future for treatment of obesity. And the current strategy is to use weight-neutral medications, or those that induce weight loss with when indicated or within the indications. For example, for diabetics, as Dr. Adil said, we have, for example, exenatide is a GLP-1 receptor agonist that when used in different concentrations will lead to some weight loss. So all the group can lead to weight loss, but with different efficacies. Also, newer medications for the use of diabetes that is not present in our country nowadays, but it is there in UK and Europe, is pramlintide. Pramlintide is a amylin analog that that could be used for treatment of diabetes with the type 1 or type 2, and it leads to significant weight reduction, but it is also an injectable one, like GLP-1 receptor agonist. In this slide, we have patients taking no drugs, placebo, and those who are taking the pramlintide. And we know that there is a difference in the weight in both groups. So pramlintide leads to a significant weight loss after 16 weeks compared to placebo. And this is, as Dr. Adi said, liraglutide compared to placebo in different concentrations of 0.6, of 1.2, and 1.8 or 1.9 here. As we increase the dose of liraglutide, we got more weight loss than compared to placebo. Also, we have leucoserine. Its trade name is pelvic. It causes a dose-dependent weight loss. As we see, we have 4 arms, placebo, and 3 different concentrations of leucoserine, 10 milligrams, 50 milligrams, and 10 milligrams PID. And we saw here that when we increased the dose, we got more weight loss. Now, as what we know that chronic diseases need combination therapy. We got more results and less side effects when combine medications from the start, like hypertension, like diabetes, like dyslipidemia. Also in obesity, it is better to combine more than 2 groups of those groups to get more results. We have propionate, we have zoncizumab, BYD analogs, leptin, amylin derivatives, sibutramine. All those medications can be combined. Okay. All those molecules can be combined together to get more weight reduction. As we see here, when using sibutramine and low dose of leptin, we have more results than using either alone. In the first, the upper row, upper line, we have leptin alone, then sibutramine alone, then both. As you see here, we have greater weight reduction when using combination therapy. Combination therapy leads to greater weight loss and fewer side effects. We have now some already present medications with fixed combination within the same tablet. We have phentermine and tubamide or Tubamax in one tablet called Quinix or Ozemia in some countries. We have bupropion and naltrexone in tablet called, its generic name is Contrav. We have propionate with zoncimide and its generic name is Empatic or Excelia. We have also amylin with leptin in the same injection. These are the trials that showed that weight loss with combination therapy after 48 weeks using naltrexone and propionate is greater than using either alone, as you see here. At the lower line, we saw that there is a greater weight reduction using propionate SR with naltrexone. Also, when using zonisamide with propioprone, we have also greater weight reduction using the combination therapy than either alone. We have here a combination of phentermine and Topamax, study called the EQUATE trial. This is the design of the trial using adults less than 70 years of age with body mass index from 30 to 45. And we have 7 subgroups. It was done in 32 investigational sites. The primary efficacy endpoint was to measure the percent of weight loss. The second one is to measure the percent of subjects achieving at least 5% weight loss. And safety assessment include adverse events, depression assessment, and suicidality, meaning suicidal attempts or suicidal actions for those using this medication. Patients achieving weight loss was greater those using both Topamax and phentermine than using either alone, and sure if more than the placebo. But the side effects are frequent. We have headache, paresthesia, upper respiratory infection, dry mouth, nasopharyngitis, constipation. Also, some psychiatric adverse events like insomnia, depression, depressed mood, history of depression, and suicidal attempts are more frequent. Also, there is cognitive adverse events, disturbance in attention, cognitive disorder, memory impairment, but those adverse events are reversible when stopping or holding the medication. We have also amylin analog, which is pramlintide with phentolamine or sibutramine produce significant weight loss, also combination therapy using pramlintide with either phenetramine or sibutramine. And the side effects here are nearly the same, but regarding the blood pressure increasement was more in patient using sibutramine with pramlintide than using phenetramine. And most of other side effects are nearly equal, but also the nausea, tachycardia, dry mouth, constipation, insomnia, sleep disorders, blood pressure changes, headache, respiratory infection, urinary tract infection, all are side effects and adverse events of this medication. And also leptin and amylin. Leptin, we know it can lead to weight loss, but when leptin is combined with amylin, we get more significant weight loss than using leptin alone. And as we see, we have leptin 25 micrograms per kg per day, and another group using amylin 100 microgram per kg per day, and the third one using amylin and leptin 25 microgram per kg per day, and it showed that amylin and leptin produces more significant weight loss. Also using amylin derivative with metroleptin, it will produce more weight loss, as we see here in this slide. The future of obesity treatment, we have to looking for better understanding of the target systems and counter-regulatory systems. Treatment that are targeted to specific control and peripheral targets will be developed. Central and peripheral targets will be developed. Rational combined therapies and medical and surgical intervention will be developed in the future. And thank you very much.